What's up, ladies and gentlemen? Welcome back to Neurosketch with Dr. Kenny. But if this is the first time you've seen this channel, don't forget to subscribe. Let's have a discussion on anterior abdominal wall. But before we dive into details, let's see the bony landmark one more time. We said we have the lumbar vertebra, we have the costal margin, we have the xiphoid process here, and as a part of pelvic bones, we saw the iliac crest here and its continuation as the anterior superior iliac spine. This is anterior superior iliac spine, but we saw we have two pubic bones that are united here by the pubic symphysis, which is the secondary cartilaginous joint, the fibrocartilage, joined by the fibrocartilage. And then on the lateral either side of the pubic symphysis, you have the pubic tubercle. Small elevations on these pubic bones, and we saw the pecten pubis here, which is called the pectineal line. Now the anterior abdominal wall is made up of 9 layers from outside to inside, but these layers are depending on which approach you're using. If you're going from the lateral approach, it's 9 layers, but if you're going from anterior approach, it's going to be a little bit different, and you're going to see why. Okay, so from outside to inside, we have the skin. After skin, we have the subcutaneous tissue, means sub below the skin. And then after the subcutaneous, we have the superficial fascia, which you're going to see it has got 2 layers. After superficial fascia, we're going to a layer of muscles, 3 muscles in total. I'm going to show you how. But the outermost one is the external oblique muscle, the internal oblique, the transversus abdominis muscle. These 3 muscles have been encountered. After the transversus abdominis, we are going through a fascia which is called the transversalis fascia or fascia transversalium. After this fascia, we still have a layer of fat, which is called the preperitoneal adipose and areolar tissue. You can just say a layer of fat or preperitoneal fat. And then after preperitoneal, we're going to the peritoneum. Okay, peritoneum. One among the visceral layer, one among the cellulose layer that is covering the wall of anterior abdominal wall and of course the posterior. Now let's talk about the superficial fascia. Superficial fascia has got 2 parts, the membranous layer and the fatty layer. The outer is fatty layer, this fatty layer, and the inner one is membranous. This is the fatty layer and this is membranous. The fatty layer of the superficial fascia is called the campus fascia. The campus fascia, superficial fatty layer of the superficial fascia. And then the campus fascia is deep membranous layer of superficial fascia, has got 2 layers. This is the outermost one and this is the innermost one. Okay, now the campus fascia is going to continue to the penis, so it loses some fat because this is a fatty layer. This is the campus fascia. Campus fascia is a fatty layer, so it's going to lose some fat to go to the penis to form one among the layers of the penis, but also going to the scrotum to form the dartos fascia, and it loses amount of fat to form this dartos fascia. Why it loses fat? Because in the scrotum we don't need insulation. You don't need high temperature in the scrotum. In fact, the scrotum have got 2 degrees Celsius lower than the body temperature to make sure the process of spermatogenesis continues in a smooth way. Okay, so the campus fascia also is going to form the choris fascia. Don't worry about this dartos and the choris. We're going to discuss them when we do anatomy of the scrotum. Okay, so these are the 2 layers of the superficial fascia. Because of superficial fascia, we also have deep fascia, but deep fascia is poorly developed. So we are going to the muscles. But let me give you, this is a snapshot of the superficial fascia. You have the explanations here. And the deep fascia, as I told you, is poorly developed. This superficial, this is membrane, the fatty layer of the superficial fascia, and this is the deep membranous layer of the superficial fascia. This is the campus fascia. Now let's go to the muscles. I told you we've seen the superficial fascia. Now let's go to the muscles. And we said you have 3 muscles that we mentioned in this 9. But this, I told you, it depends on the approach. If you're going from the lateral approach, we see we have 3 muscles. What are they? We have the external oblique, the internal oblique, and transversus abdominis. External oblique, internal oblique, and transversus abdominis. But if you are going through the midline, through the anterior approach, you are going to encounter a different muscle which is called the rectus abdominis. Now, these muscles are not found anteriorly, and this rectus abdominis is not found laterally. So it depends on what incision. If you're going through lateral, you're going to encounter 3 muscles. If you're going through median, you're going to encounter 1 muscle and probably the extension, which are called the aponeurosis of these muscles. We're going to see later today. Yeah. So these layers after these muscles, 3 or 1, depending on approach, you're going to encounter another layer which is called the transversalis fascia. This one in the I don't know, this darkish here, the transversalis fascia. You're going to encounter it when you are after entering these muscles. Transversalis fascia. After transversalis fascia, what do we have again? We have the layer of fat. This one, this fat layer here. This fat layer we've said is called the preperitoneal adipose. Now, after adipose tissue, now you have, because it's called the preperitoneum. After that one, you have peritoneum. Then this is the inner. And this picture summarizes all the 9 layers of the anterior abdominal wall. Yeah, so for our interest today, let's discuss about these muscles, the muscles of anterior abdominal wall. So these are the muscles we've seen. We have 4 muscles: external oblique, internal oblique, transversus abdominis, and rectus abdominis. What is the function of this muscle? This muscle, they move the trunk by flex and lateral flexion. So you'll be hearing, when you're discussing each muscle in turn, you'll be hearing that this one does flexion, this one does the lateral flexion of the trunk. They move the trunk in that fashion. But also, because they are layers of the anterior abdominal wall, one among the function of layers is to protect. So they have the protective function. And what do they protect? They're going to protect the abdominal viscera. Okay, they're protecting the abdominal viscera. And lastly, these muscles, they are tensing the abdomen. They are increasing compression. They are compressing the abdomen, and they are compressing this abdominal viscera. By compressing the abdominal viscera, they are increasing intra-abdominal pressure. And the other time I asked you, why do we need to increase intra-abdominal pressure? You need to increase the intra-abdominal pressure for you to cough. Remember, you cannot cough without tense your abdomen. This is impossible, okay? For you to sneeze, you cannot sneeze without, tense your abdomen. And these muscles are helping you to tense, okay? So no rectus abdominis, no these abdominal muscles, there is no coughing, no sneezing. Okay, and what happens if you don't have coughing? You're going to have respiratory infections every now and then, because you're gonna, coughing is one among the mechanism of removing the unnecessary bacteria that you might have, they might have get access into your respiratory system. Same apply for sneezing, and also you need to pee at some time. So urination is made possible by these muscles. No these muscles, no compression of the abdominal viscera, no intra-abdominal pressure, and no peeing. Imagine. So you cannot pee without these muscles, and defecation as well. But also during child delivery, vaginal delivery, when you tell the mama to push the baby, so she is pushing, but what actually create that pressure of pushing is these muscles of the anterior abdominal wall, the anterior abdominal wall, and they are very, very important. You can never ever forget about these muscles. So this is summarizes, but also these muscles have something in common. Also, innervation of this muscle is gonna be through the thoracoabdominal nerves. The thoracoabdominal nerves, these are coming from the thorax and the abdomen. Thoracoabdominal. So you will have lower 5 intercostal nerves plus subcostal. This one you should write. Lower 5 intercostal nerves plus subcostal nerve. They are forming the thoracoabdominal nerves. But again, to some muscles you'll be hearing, you have the lumbar nerves, lumbar 1 nerves. But the biggest part is thoracoabdominal. This one. Now you know how important these muscles are. So we have a situation in which a baby is born without these muscles or have weak abdominal muscles. This condition is called the Prune Belly Syndrome. Prune Belly Syndrome is a condition in which there is an absence or weak abdominal muscles. And what happens to this baby with these complications? Remember, we've said coughing is important to remove the bacteria. So these babies suffer, respiratory infection every now and then if nothing is intervened. But also, as part, we've said defecation and removing and urination is made possible by these muscles. So assume without urination, this baby is going to suffer the chronic urinary tract infection (UTI) because of stasis of the urine, and also they have constipation, long-term constipation, because they cannot defecate, they cannot tense the abdominal muscles, the abdomen, to remove these waste products. Okay, let's discuss each muscle in turn, starting the external oblique abdominis. This muscle here is called the external oblique abdominis, and the external oblique abdominis continues as the aponeurosis. We said that at the time the aponeurosis is like flattened tendon, a flattened tendon. So this is like a tendon of the external oblique abdominis. Now the external oblique abdominis is running in inferior medial direction, and we say it's like you are putting your hands in the pocket. So hands in the pocket direction, that's the direction of external oblique abdominis. This muscle is oblique to the midline. It's oblique to the midline. This is why it's called the oblique. But it's external because we have internal oblique abdominis. This is external oblique abdominis here. What's the origin of external oblique abdominis? The external oblique abdominis is arising from the lateral surface of lower 8 ribs. That means from rib number 5 to rib number 12. Yes, to rib number 12. And you see, this muscle is called the serratus anterior. And as we said, the serratus anterior is interdigitating. But today I'm telling you that it interdigitates with the external oblique abdominis. Remember, the interdigitations, you need to have two hands, this and this. So this is coming from the serratus anterior, and this is coming from the external oblique abdominis muscle here. So that's the origin. What is the insertion? This muscle is going to insert to the linea alba. From the xiphoid process, linea alba is going to insert the pubic crest and the pubic tubercle, and then it's going to insert on the anterior half of the iliac crest here, until to the iliac crest. Yeah, it leaves. We're going to see later how it forms. It forms part of the inguinal canal and inguinal ligament. Here, the external oblique abdominis, as it winds downside, let me show you. So it comes in this direction. Let me show you here. So it comes in this direction, and then as it approaches the lower part, it winds up posterior, and then it creates like a canal here. So it forms a part. The inferior margin of external oblique abdominis is forming a part of the inguinal ligament. You're going to see how. What about innervation of this muscle? We've said this muscle has been supplied by the thoracoabdominal nerves. What's the function of this muscle? We've said it tenses the abdomen, it compresses the abdominal viscera, but also it acts in the movement of the trunk. So what movement? This is lateral flexion, because this muscle are lateral. They are helping lateral flexion of the lateral flexion of the trunk. Next, we have the internal oblique abdominis, and the internal oblique abdominis is running in perpendicular direction to the external oblique abdominis. We have said the external oblique is running in inferior medial as you're putting hands in the pocket, but the internal oblique is running in this direction. Okay, so they transect one another at 90 degrees. What are the origin of the internal oblique abdominis? The internal oblique is coming all the way from the thoracolumbar fascia, the anterior 2/3 of the iliac crest, and the lateral third of the inguinal canal. This is the origin. The thoracolumbar fascia, the anterior 2/3 of the iliac crest, and the lateral third of the inguinal ligament, and it's going to insert itself to the xiphoid process and linea alba. But downside here, see, this is the same internal oblique muscle, and it's going to leave a slit here. It's going to form the conjoined tendon. So it's going to join the transversus abdominis to form a conjoined tendon. We're going to see it, the conjoined tendon. But in my experience, I think these muscles do not stress much knowing about the origin insertion. I think more of the action and they're more likely to be asked than the origin insertion. But it's far better also to know the origin insertion of these muscles. Yeah, so that is the internal oblique abdominis, origin and insertion. Next, we're going to discuss about the innervation. What's innervation of this muscle? It's going to be innervated by the same nerve, the thoracoabdominal nerves, now plus the first lumbar nerves. These are ilioinguinal and the iliohypogastric. We're going to discuss about these muscles when you're doing they sound a little bit difficult for you to memorize, but they're easy. Ilioinguinal because running from the ilium to the inguinal region. Iliohypogastric running from the ilium to the hypogastric. Hypogastria, very easy. I told you that at the time anatomy is easy when you link to the Latin origin. It's easy for you to remember. Lastly, what about the action of this muscle? Same as external oblique, because they are learning oblique, they are found laterally. They're going to flex, the lateral flex the trunk. But because they are forming a layer of protection of the abdomen, they're going to tense the abdomen and also to protect the abdominal viscera. Next, let's discuss about the transversus abdominis. Transversus abdominis is deep to the internal oblique. After removing the internal oblique, you find the transversus abdominis, and this muscle is running in a transverse direction, in horizontal direction. This is what's called the transversus abdominis. What's the origin of the transversus abdominis? Same as the origin of the internal oblique. What do we say about the internal oblique origin? We say it is starting from the thoracolumbar fascia, the anterior two-thirds of the thoracolumbar fascia posteriorly, the anterior two-thirds of the iliac crest, and the lateral half of the inguinal, the lateral third of the inguinal canal here. But on top of this, it also goes origin from the internal surface of the lower costal margins, the lower costal cartilages, from costal cartilage number 7 to number 12. Remember, the thoracolumbar fascia posteriorly, the anterior two-thirds of the iliac crest, the lateral third of the inguinal canal, and plus the inner surface of the costal cartilage from rib number 7 to rib number 12. That's the origin of the transversus abdominis. And in fact, the transversus abdominis is going to interdigitate with the diaphragm inside, because inside here and the inside we have diaphragm. It's going to interdigitate with diaphragm. What's the insertion of this transversus abdominis muscle? So it does go to aponeurosis. This aponeurosis is going to the linea alba. Here to the linea alba, we're going to see how, and then part of it is going to join the fibers of the internal oblique to form a conjoined tendon. I told you the other time, I told you shortly that it's going to form the conjoined tendon. The conjoined tendon is formed by two muscles, the aponeurosis of two muscles, the internal oblique abdominis and transversus abdominis are going to form the conjoined tendon. What is innervation of this muscle? Same as the innervation of the others, the thoracoabdominal nerves plus the first lumbar nerves. What are the first lumbar nerves? That's this is the ilioinguinal and the iliohypogastric. They are easy. We're going to see that. What the function of this muscle we have said several times. Last, let's talk about the rectus abdominis muscle. This is the rectus abdominis. The meaning of rectus is straight. So this is the straight muscles of the abdomen, because we've seen the oblique muscles and we've seen the horizontal muscles of the abdomen. This is the rectus abdominis, the straight muscle of the abdomen. Now, the straight muscle of the abdomen has got partitions, and this partition is what gives the six packs pattern. So you say someone has got six packs, it's because of visibility of these muscles to the skin. Remember, before we go to these muscles, we have subcutaneous fat, whatever, superficial fascia and whatever. So if someone has got a huge campus fascia, means fat layer is big, and that in that person, the visibility of this muscle is difficult. Okay, but if you clear that fat by exercising, like this guy here, exercising a lot, you're going to we're going to make this muscle visible. And this is, so everyone has got these six packs. Okay, but visibility differs depending on the layers of their layer of fat which is anterior to this muscle. Yeah, so this is the rectus abdominis. Midline we have the linea alba, and I told you that at the time linea alba, because it's white, and white appearance is because of this sheath. Yeah, so this is linea alba, and the linea alba is separates these two muscles into left and right by the linea alba. And then we have the small intersections which are called the tendinous intersection. We saw them at the time. These are the tendinous intersection here, tendinous intersection. What is the origin of this muscle? This muscle is coming from the pubic crest and the pubic tubercle all the way to insert to the xiphoid process. So when this muscle contracts, it pulls the xiphoid process toward the pubis, and for this you're going to have flexion of the trunk. Flexion of the trunk is achieved by the rectus abdominis. Rectus abdominis muscle. Extension of the trunk is made possible by the muscles of the back. So when they contract, they pull the trunk posterior, so they're causing friction. But the rectus abdominis is going to flex the trunk. And this is why also when you want to train, when you want to get six packs, you are doing these sit-ups. Sit-ups is Why? Lastly, we haven't seen a certain muscle. We have a small muscle here, anterior to the lower part of the rectus abdominis. This muscle is called the pyramidalis. Pyramidalis. It's a pyramid like this one. This muscle is absent in about 20% of population. So not everyone has got the pyramidalis, but some, even in your dissection, you can see some cadavers got this muscle. It's called the pyramidalis. The function of pyramidalis is just to tense this linea alba. Linea alba. Okay, now let's see the rectus sheath. Well, we have a fibrous sheath which is covered in the rectus abdominis muscle. This is the rectus abdominis muscle, and this is the rectus abdominis muscle. We have a fibrous sheath which is covering the rectus abdominis muscle, and this sheath is formed by the aponeurosis of these three muscles: external oblique, internal oblique, and transverse abdominis. They are forming the aponeurosis, and these aponeurosis are going to cover the rectus abdominis muscle. But this is variable depending on different regions of the body. Let me show you here. For example, above the costal margin, so above the costal margin, the rectus abdominis is formed only by the aponeurosis of external oblique abdominis only. Above the costal margin here, the rectus sheath is formed only by, the anterior layer of the rectus sheath is formed only by the aponeurosis of external oblique abdominis. This is the rectus sheath, this is the rectus abdominis, this muscle, and then this is aponeurosis of external oblique. And you can see there is nothing else that is forming the anterior layer of the rectus sheath. At this region here, between the costal margin and the point halfway between the umbilicus and pubis, this region here, the rectus sheath is formed by all three muscles, by the aponeurosis of all these three muscles. What are they? External oblique, internal oblique, and the transversus abdominis. And what happens is, the rectus sheath gets two layers, the anterior layer and posterior layer. The anterior layer of rectus abdominis is formed by the external oblique and so at this location here, this region between the costal margin and a point halfway between umbilicus and the pubis, this region here, the rectus sheath is formed by the aponeurosis of all three muscles. What are they? External oblique, internal oblique, and transverse abdominis. And this happens in such a way that the external oblique passes anteriorly to the rectus abdominis, so it forms part of the anterior layer of the rectus sheath. The transverse abdominis passes posterior to the rectus abdominis, so it forms part of the posterior layer of the rectus sheath. And what happens to the internal oblique? The internal oblique at this level, it splits into two. The aponeurosis of internal oblique is split into two parts. So it has got the anterior lamina and the posterior lamina. The anterior lamina is going to join the aponeurosis of external oblique to form the anterior layer of the rectus sheath. But the posterior lamina of the internal oblique is going to join the aponeurosis of transversus abdominis to form the posterior layer of the rectus sheath at this region. Very, very important. And lastly, below this region here, below this upper here, we have only all the aponeurosis of these three muscles that are passing anterior to the rectus abdominis. All aponeurosis of these three muscles are passing anterior to the rectus abdominis. So nothing is passing posteriorly in terms of this aponeurosis, and that's a big difference. And I think this is tricky. It sounds like an exam question, okay? Like anteriorly, above the costal margin, is made only by the external oblique abdominis, and then this region here formed by three, but remember the internal oblique is splitting into anterior and the posterior, and then below this region, the rectus sheath is formed. All the rectus sheath are passing anteriorly to the rectus abdominis muscle. Yeah, so we have something which is called the arcuate line of Douglas, and the arcuate line of Douglas this is the lower border of the posterior of rectus sheath. This marks the end of the posterior border of the rectus sheath. I've told you. The rectus sheath at this region has got anterior border and the posterior layer and the posterior layer. But when you go down here, there is no posterior border, so it disappears. And the point where this posterior border disappears is called the arcuate line of Douglas. Arcuate line or line of Douglas, the same name. Okay. And also at this region here, the arcuate line of Douglas is where the inferior epigastric artery and vein, they are getting access to the rectus sheath to go to supply these muscles and the structures of the anterior abdominal wall. Now lastly, let's discuss about the ligaments around the anterior abdominal region. First, we have the inguinal ligament, but we're going to discuss inguinal ligament when we are doing the anatomy of the inguinal region, so don't worry about it. But we know it's formed by the aponeurosis of external oblique abdominis. The inguinal ligament is also called the Paupert's ligament. The Paupert's ligament. Don't worry about it. We're going to discuss it when we are doing next time. But we've seen that you have the conjoint tendon, which is formed by the aponeurosis of the internal oblique and the transversus abdominis muscle. They're forming the conjoint tendon with the umbilical cord. So these are remnants. They are called the ligaments. So this is the median umbilical ligament. Is a remnant of the urachus. Let me use this picture here. So we have these ligaments here. They are called umbilical ligament. You see, you have median umbilical ligament, the medial umbilical ligament, and the lateral umbilical ligaments. So they are umbilical, meaning they are related to the umbilicus. And what was the function of umbilicus? To connect the mama and the baby. Okay. Now, for example, the median umbilical ligament is the remnant of urachus. And the urachus was used to transfer urine from the baby's bladder to the umbilical cord for excretion. Okay, this is urachus. So the median umbilical ligament, and this sounds like exam question. I mean, I'm sure most of the questions until abdominal wall, they will ask you about these ligaments. Okay, so median umbilical ligament is a remnant of urachus. Here we have the medial umbilical ligament on either side, one on this side and one on the other side. And this medial umbilical ligament, they are remnants of umbilical artery, remnants of umbilical arteries. What happened to the umbilical veins? You remember we had two umbilical veins, left umbilical vein and the right umbilical vein. The left umbilical vein was going to went to form became the round ligament of the liver, or also called the ligamentum teres hepatis. The left umbilical vein. The right umbilical vein disappeared. So it obliterated, it disappeared. But the umbilical arteries, we have right and left, and they are forming these medial umbilical ligaments. And then lastly, we have the lateral umbilical ligaments, and the lateral umbilical ligament, they are housing the inferior epigastric arteries, Now, remember, some books you will see they are written as medial umbilical fold. So fold is meaning this ligament is covered by a membrane, by a layer here. For example, this one could be called the medial umbilical fold because it's covered by a membrane. But once it's not covered like this one, it becomes a ligament. So the same thing, umbilical ligaments or umbilical folds, they mean the same thing. Next, let's see the blood supply of the anterior abdominal wall. So we have two major blood arteries, that are supplying the anterior abdominal wall. We have the superior epigastric artery and the inferior epigastric artery. The superior epigastric artery is coming as one among the terminal branches of the internal thoracic artery. Remember, the internal thoracic artery will terminate by forming two terminal branches, the superior epigastric artery and the musculophrenic artery. But the inferior epigastric artery is coming from external iliac artery, and it's going to supply this region. So the anastomosis around this region, superior and inferior, but also have intercostal, the lumbar arteries that are coming from the abdominal aorta. I'm sure you've watched the discussion of the abdominal aorta. Okay, we discussed about names the other time. We have dermatomes, and we said of clinical importance is dermatome T4, which is supplied around the nipple, and T10, which is supplied around the umbilicus, And you also remember that all the spiral nerves, they are mixed nerves, meaning they have motor and sensory fibers. Last, let's see the incision of the abdominal wall. So we have a lot of incision in abdominal wall, and these are different approaches that surgeons can use to get access into the abdominal viscera. Okay, but for today's discussion, we're going to concentrate on this one, the midline incision, number 3, midline incision, and the paramidline incision. But also see you have a coccus, this is coccus subcostal, which is called coccus incision. You have the Mark Barnes, and I'm sure now you know the Mark Barnes point. Then we have a Mark Barnes incision, but also have the finestio. This one famous, used by cesarean, for cesarean section. We call the finestio incision, and you can have the transverse incision. Okay, but let's concentrate in what what is ours. Is ours is this number 3, which is called the midline incision. And the midline incision, I told you again, if you're going through anterior approach, you're not going to encounter these muscles. So on those 9 layers of the abdomen, you will not encounter these muscles. And if it's midline, meaning you are not encounter any muscle here. So it's going through the linea alba. So you know the layers anterior to it, and then you go through the linea alba all the way going to the to the this fascia transversalis and the deep the preperitoneal fat, and then to the peritoneum. This is the axis we're going to use in the midline. These are the layers we're going to use. And this sounds like exam question again. I mean, you'll be asking someone is doing a midline incision, what layers are they going to encounter before reaching the abdominal viscera? Then these are the layers, midline through the linea alba. Okay. Now the linea alba is has got no major vessels, and is preferred for emergence incision. But again, if someone wants to separate the rectus sheath into left and right, they are going through the linea alba. But in non-emergent situation, people would avoid the midline incision because healing is usually poor and is associated with abdominal hernia of the anterior abdominal wall. Yeah. So next, we have the paramedian, because para means around. So this is the paramedian incision here, paramedian incision. And then this paramedian incision, you see, we have what? The muscle. Which muscle? Rectus abdominis. So in this situation, you encounter the whatever, and then you will see the anterior layer of the rectus sheath, and then you go through rectus abdominis. After rectus abdominis, you are going through the posterior layer of the rectus sheath, and then the other things are continuing as we have seen the other time. Yeah. So most of the time people tend to avoid the midline incision unless it's emergence. So we have a question here. Decision is made by surgeon to perform emergence exploratory laparotomy on 42-year-old male with severe abdominal pain. This is emergence, severe abdominal pain. Which of the following is the most appropriate incision to separate left and right rectus sheath? So, should you put your answer in comment? Yeah, but let's make it. It's linea alba. Why? Because number 1 is in emergence. When you forget about being emergence and whatever, but it is it separates the left and right rectus sheath. Let me take you back here. This is the left rectus sheath, this is the right rectus sheath. What separates between here is through the linea alba. So this incision will be through the median, and it's going through the linea alba. Alright guys, see you in the next discussion.